To welcome everyone to our 15th of these Bounce Back book clubs. And these clubs are based on the chapters in the Bounce Back Critical Care book. There are 6 sections, and we are honored to have our section editor for section 3. This is the last chapter in section 3. So we sort of did it in a clever way. A is chapter A, airway, chapter, or section B is breathing, section C is more cardiac circulation. And so this case today is interesting because it's one of those cases where we think to ourselves, wow, after resuscitation, some high fives, leave the room, and go see the next patient. But in the end, really, this is a job that is really just beginning in this type of patient. So we're going to talk about this patient in a second. I wanted to welcome folks and let you know that in just half a second here, I'm going to flash the barcode so everyone can get their free CME for this. Now, I wanted to also tell you that we are taking a summer break. So we have summer break, and as it turns out, the first Monday of the month of September is Labor Day. So we start back again on October 2nd, and you can always sign up for these book clubs at my website, embouncebacks.com. It's EM like emergency medicine. So this is the 15th chapter. We are exactly halfway done with the book, and I wanted to introduce folks here. I'll put up the QR code. There are no financial disclosures from anyone here, so that's nice. So this is the code. You can use that QR code to get your CME credit. John Greenwood is our section editor. He's both EM and critical care, assistant professor, Department of Emergency Medicine, Department of Anesthesiology and Critical Care, Perelman School of Medicine, University of Pennsylvania. Also, Emily Hammer, and Emily is one of the 2 chapter authors for this chapter of the 81-year-old man who has a post-arrest care and demonstration of that. Emily is a assistant clinical professor at Michigan State University College of Osteopathic Medicine in East Lansing, Michigan. We also have Scott Kobner. He is an emergency medicine physician at the USC, and he is also the medical director of MRAP. So honored to have you with us here, Scott. And then Mike Palacci, a friend as well as fellow past core faculty member, as well as fellow researcher, who is a emergency physician, Department of Emergency Medicine, Suma Health System in Akron, Ohio, and director of their sim lab there. So really a nice panel that we have here together. And we'll just sort of jump right in. And I want to tell you about this patient. And like we always do, we'll start with the story. And I will say also, just as far as the website, in addition to signing up for future book clubs, you can also watch almost all of the past book clubs. And they're sort of recorded in full. And so you don't need to have the book, don't need to have any of that information, but just some really nice discussion by some really well read and well learned and amazing teaching emergency physicians from around the country, as well as specialists too. So I'm going to give you the story here. This is Thomas Wyman. He's an 81-year-old man. He had BPH, but he had failed medical therapy. So on June 17th, he has an outpatient TURP. Uneventful, Foley catheters left in and removed a couple of days later. He's discharged for routine outpatient follow-up. And on post-op day 5, though, he was doing well before that, but he wakens not really feeling right, gets dressed, goes down for breakfast. He's not hungry. He sits in front of the plate that is prepared by his wife. He's not eating. Eventually goes in the family room to watch TV. And soon after, his wife realizes that she has not heard from him for a while, enters the room and finds her husband still on the couch, conscious but confused and gray. She tries to get him the car, but is unable. She feels panicky and calls 911. So our story really starts here with the patient's arrival from the paramedics into the emergency department. The patient was short of breath, the paramedics say, when they arrived, but soon after he went into full cardiac arrest. So this was a witness arrest. The emergency physician does know that he had prostate surgery 5 days ago. So in addition to being a witness arrest, also that unique patient of a recent post-surgical patient. The patient received epinephrine times 3, bicarbonate. The patient was intubated. He regained a pulse when they were leaving the house. He lost it en route. Chest compressions were resumed. He had a Lucas device. And then when he arrived in the emergency department, the Lucas device was turned off, and he had a regular rhythm as it was documented. And He had a heart rate of 90. So you can see the medications that he has there. There's not really much more known about this patient. So what we're going to do is start in, as we always do with these Bounce Back Critical Care book clubs. We have three unique decision points, and we'll go through each of those decision points. We'll have a discussion of some main questions. We'll see what the actual provider did, because what you're seeing here is the actual documentation that was on the chart. Then we'll see what happened to the patient, and we'll move to our next decision point. So we're going to start things off here with this patient, and we're going to start things off with our chapter author, Emily Hammer. So, Emily, I think we all sort of know this and we do it, but having a post-arrest patient, or maybe a patient that we think is in a full arrest, arrive, there's a lot of people in the room, a lot of stuff going on. Everyone's looking at us, right? So obviously, this is like an hour-long discussion of what are some of those first steps, but what are the things that you really hang your hat on when you first walk in that room? The paramedics arrive with the patient on the stretcher, they're getting ready to move him over, even before you have an opportunity to start your exam on the patient.
So, most codes you walk into are pretty messy, right? They they have a lot going on. There's a lot of people, a lot of chaos. So I made a little mnemonic to help clean up your mess, and it's bleach. So I kind of like to start off with the B. So blood pressure. What kind of blood pressure am I working with? Labs. What kind of labs can we get? Like we need a CBC, a chem, trope, coag, CBG, basically a rainbow. Um, and then next is E. I'm gonna get that EKG, right? I am worried about that STEMI, that post-arrest STEMI that might need emergent heart cath. Um, I'm looking to see if I have an airway. In this case, they did have an airway. But if I had like a king airway in or not, no definitive airway, I would take care of that. The way that we could confirm airway in this case is direct laryngoscope. You can use capnography, auscultation, visualization with bedside ultrasound. And that kind of leads me to C, which is capnography, maintaining that CO2 35 to 45. Next is H, hypothermia, which we're going to probably talk about later on in this discussion. But when we wrote this chapter in 2017, 2018, hypothermia protocol was still like a gold standard of practice. So that's why we can include the H. And then oxygen. How am I oxygenating the patient well? Are they hypoxia? They're hyperoxia. I want to maintain my SpO2 like 94 to 99%.
So, Emily, I'm going to ask you a couple follow-up questions,
Hmm.
and some of them will be sort of straightforward yes and no. So you said labs. Of course, we all write for those basic CBC, BMP, the troponin.
Hmm.
This patient is a post-surgical patient. Would you add a D dimer onto this patient just with the
No,
thought that he could have had a PE?
no. It's, I mean, that's just worthless, right? It's going to be elevated from surgery anyways. So, no way.
And you're not going to have the result back for an hour. So, I mean,
Yeah,
hopefully, if that's what caused this patient's arrest, we're addressing that in other ways. So, we'll
exactly.
talk about the hypothermia more in just a second here. But as far as like confirming that airway, that's one of those things that can really trick us up because, first of all, it's a paramedic that placed it without all these resources, probably not with a video laryngoscopy,
Hmm.
but yet they maybe have an esophageal intubation, or maybe in transferring the patient from the patient's floor in their living room to their cot, or their cot to the truck into our cot, that could be dislodged. So you mentioned capnography, listening to the lungs. Are there some sort of hang your hat on sort of ways that you're going to try to confirm that airway? Or you figure, look, if you got mist in the tube and the SAT is good and capnography shows color change, we're pretty much good to go.
So for me, I work at a teaching hospital. So we're going to bring that intern in and say, okay, you're going to take the laryngoscope, you're going to take a look and see where this tube is. Glide scope if they prefer that. Um, I kind of like the glide scope anyways, because then we can all see it and all kind of confirm. Capnography is huge too. Um, you can do auscultation. That's really easy. Doing a chest x-ray is not very reliable and it takes time and you have to call x-ray over stat. There is also confirmation with ultrasound, but you have to be, pretty confident in your skills with that. So for me, I think direct visualization is probably my number one.
Okay, gotcha. And then final question here. We talked about oxygenation. What is your target? I should say, what's the lowest target oxygen that you're sort of looking at for this post-arrest patient?
Like 94.
Okay.
I don't really want anything, because once you start hitting that 92, you start going off that oxygen curve, and then all sorts of badness happens.
Okay, good. All right, Mike. So let's move to you, Mike Palacci. And I'm wondering about this external compression device because you would think theoretically it's like awesome and it's going to give the exact amount of perfusion that we want. But, the studies really haven't shown that to be true.
Right. Yeah. In terms of clinical outcomes, Mike, I mean, we can look at a bunch of individual studies, but the best information that we have is probably from the meta-analysis that was done by Lee a few years ago. That's L.I. Lee, uh, which I think a lot of people are aware of. They looked at 12, they did a meta-analysis of 12 studies were done on this topic, almost 12,000 patients, and found there was really no improvement in mortality, no improvement in neurologic outcomes. And there was also a subsequent Cochrane review that found essentially the same thing. Now, it is important to note that while these studies, put together didn't really show benefit for using the Lucas device, they didn't show harm either. So, I mean, as long as it's placed correctly, just like if we're doing manual CPR, the hands have to be placed correctly. As long as it's placed correctly, it's not better, it's not worse. But the benefit it can provide, even though if it doesn't provide a mortality benefit or a neurologic benefit, it can provide the benefit, especially if you're in a resource poor environment, of freeing up a set of hands to do something else. So in the back of a truck where it might be hard to deliver good compressions as you're going over bumps in the road or where you have a limited number of people, or if you're in a small rural ER where it's basically you and maybe one or two nurses and there's lots of tasks with not a lot of people to perform them, freeing up that extra set of hands could be beneficial. But in terms of the actual compressions, the clinical outcomes from that, no difference.
Yeah, and it's sort of funny, like where I work, where we used to work together. I mean, some of those transport times, 20, 30 minutes. I'm thinking
Right.
like, man, by the time you get here, we're gonna sort of know, right?
Right.
I mean, 30 minutes into your
Well, and,
resuscitation,
and
it's
if
sort
you're
of like,
30 minutes in and the same guy's doing CPR, you might have two patients by then, because the guy that's doing compressions for the last 20, 30 minutes might be your next patient because he's just,
yeah, yeah, right,
exhausted,
exactly.
rhabdo.
Yeah, yeah, exactly. The other thing I wanted to really mention is, and sometimes I see this, is that like of all the things that we do, I think there's controversy in epinephrine and like lidocaine. I mean, how much does that really do? But in the end, the chest compressions and doing good chest compressions. So we have, I think a lot of places do have this little device and it sort of tells you if you're, pressing deep enough or fast enough and it sort of like gives that feedback. But it's so interesting to me how often it has to correct the person doing chest compressions, making me think that like when we were doing chest compressions before we were using that device, they probably weren't being done that well. So, John, let me sort of get a little bit of a rubber meets the road question for you here. So, we've got a witness arrest patient. He's 81 years old. So, obviously, not a child, someone that is now post surgical, and we have that information. What is your differential diagnosis? Because that's going to guide a lot of the different interventions that we're going to do on this patient.
Yeah, absolutely. I think now that this patient's post arrest and understanding, I guess he has some vital signs. In the back of my brain, I'm kind of going through a very broad differential diagnosis, and that probably includes starting off with a simple rush exam to really understand the phenotype of what's going on within this patient of like their hemodynamics. Because I'm thinking about diagnoses, but I'm looking for clues to get me there. So number one, two, and three, given that they just had a surgical procedure, is probably going to be either bleeding or some post procedural complication. This patient had a TERP, so it's very possible that they have new onset renal failure and some metabolic electrolyte abnormalities that kind of led into this. But I'm also thinking, well, post-procedural MI is something that can happen. They may have been taking some pain medications, right? So sounds like they were asystole or PEA arrest. So, was this a pure respiratory arrest because they were taking some oxycodone and kind of overdid it? So, that could be another thing to kind of add in. Now, you know, you can go on and down the list. So certainly, PE and then your other H's and T's could come in if you're, talking to your residents. But, at the end of the day, I'm trying to find clues as to what could be causing this. So the initial tests, diagnostic tests that you choose to do are really important. And for me, it would be a rush exam, bringing the ultrasound to take a look at cardiac function, filling, whether or not this patient needs fluids or is possibly bleeding, or signs of obstructive shock. So it's a very broad differential.
So, John, a little follow-up on that, because I think
Yeah.
to myself, say you had a patient, not this one, but with a tension pneumothorax. Well, that's
Sure.
going to clinical diagnosis. Obviously, you're going to take measures, needle decompression or whatever you want to do to totally relieve that in very quick fashion, right? Well, this patient, I mean, the things that you mentioned are all treated totally differently. So the patient's post-surgical. Is there bleeding? Is he anemic? Did he bleed because of hypovolemia? Maybe the patient, because of the surgery, had an infection and he has sepsis, or maybe it's a PE, or maybe he's taking the pain medications, or maybe it's a post-surgical MI. I mean, like all those things are like totally different the way that they're managed, right? Are you using some type of therapy? In other words, are you trying to just based on what you think is your biggest suspicion for any of those things, starting treatment before you have confirmation with testing, i.e., giving thrombolytics for a possible PE? And then, of course, hopefully that's not the bleeding, right? Or giving a transfusion, or maybe, giving calcium for potential hyperkalemia. Are you doing any of those things based on just your bedside evaluation? Or are you going to try to confirm some of those with testing, and which things you're going to look for as far as the more likely things that might be occurring?
Yeah, absolutely. So the answer is no. There's not a lot of empiric stuff that I will do here. And what I teach my trainees, as well as any of the clinicians that I work with, is moving slow is sometimes moving a lot faster than what you might think. And sometimes it's okay to take 2, 3 minutes for a clinical pause to get some data. And there's not a lot of things where that patient's going to code if you don't have that information in that fast of a period of time. But making the right decision, making meaningful interventions early on, are what's actually going to change the trajectory of this patient. So I'm doing an ultrasound, I'm getting a blood gas. Even if it's a venous blood gas, that's fine. There's a lot of really important information on that. You'll get a hemoglobin, you'll get some basic electrolytes, and a pH, which is going to be really important here. And then maybe we'll get a while this is all happening, we can get a quick EKG, and within 5 minutes, I'll have actionable data to help me understand if I need to do an intervention now that's going to prevent this patient from rearresting. So empirically treating something, no. Gathering data quickly, yes.
Okay, and so I'm going to put some words into your mouth, which I'm sure that you will agree with, as one of those things to gather data. One of the first things that I like to do is just to make sure we get that EKG, because if that patient arrests again, then you just don't have that information. And then if you resuscitate him, you got to sort of start from scratch, which brings me, Scott Kovner, to you, because I was going to ask you to speak about one of my very favorite studies, just an incredibly well done study published in New England Journal of Medicine. And for years, we thought to ourselves, I thought to myself, it's like, well, I mean, what happens when you're 80? Why do you arrest? Of course, it's because you have a heart attack. So shouldn't all those patients just go to the cath lab? It makes tons of sense. We know that that's actually what causes arrest in so many people that are in their 80s, right? So why don't we just take them all to their cath lab, to the cath lab? But Lemke's looked at this very question, and not only did he look at this question, but he did follow-up studies that really confirmed what this original study showed.
Yeah, I think this is a great paper to discuss and certainly has changed, I think, the way a lot of centers at least coordinate with cardiology and post-arrest patients. But I think the first most important thing that you said is like getting that initial EKG. like I work with residents, work at a busy trauma hospital, and like, like it almost seems like the moment you palpate that femoral pulse, the EKG button is pressed. And sometimes that can almost be problematic, right? You just slammed 1 milligram of epi into this person that has some degree of like greater than 50% stenosis throughout all of their coronaries. And you've almost given them a little like chemical stress test in that moment post ROSC. And so that first EKG, sometimes if taken really quickly right after a big stressor, can show like diffuse depressions and like elevations in AVR, something that you might think is like a STEMI mimic, or because they're tachycardic like AFib RVR, that could make you believe that this person might actually have a STEMI, when if you just waited like maybe 5 minutes, let stuff settle out, sort of what John was saying, getting the rest of your information. Normally, if you time an EKG just right, having some of those stressors resolve, you can get a better picture of what's actually going on from an ischemia perspective of the heart. So this study basically put the nosh on getting just routine angiography post ROSC. And so specifically, this group looked at about 500, I think 50 some patients that did not have a STEMI on post ROSC ECG. So this is a group that did not have any sign of ST elevation that would count by like typical definitions of STEMI, nor did they have ST depressions in the anterior leads concerning for posterior STEMI. And they randomized them to immediate coronary angiography or delayed until neurologic recovery post ROSC. And they found at 90 days, essentially, that the survival was essentially the same. And so, conventional thinking being that if you don't have a cause for cardiac arrest, there's about 70% of the time there is a cardiac cause. It's not a clear STEMI. We used to say maybe get that angio, maybe there is something there that's intervenable. This study would suggest that it's okay to actually wait if you don't see a clear STEMI, regardless what's going on, until there's some time in the ICU, there's a little bit more stability with the patient. Basically, this is a study funded by cardiologists so that they can get a good night's sleep, play some golf in the morning, and come in for those patients afterwards. But totally right. This excludes people that are in like refractory VFib, VTAC. This also excluded patients that you had a primary cardiac concern, that had ECMO, that had other things that might draw you to want to get somebody to the cath lab because you really believe that there was something intervenable going on.
Okay, Scott, so I'm going to keep you on. We're going to talk about another study. I'll just review that one super quick. And we were talking about this a little bit before the program started. And this will end our section one. We'll sort of move on to see what happened with the patient and then go at our next set of decision points. But it's sort of funny when I think of, again, the olden days. Why am I talking about the olden days so much, right? But like with chest pain, when they brought the patient the Mona, MONA mnemonic, like the morphine, it's like, oxygen. It's like, well, the nitrates, I'm not a huge fan. And the aspirin, it's like, okay, you're going to give them like 325 of aspirin to inhibit their platelets when they have a big clot sitting in their LAD. Probably is not going to do a whole lot, right? So, in the same way, Emily was talking about when she wrote this chapter just a few years ago, we did therapeutic hypothermia. And this study here by Dankowitz, which really just came out in 2021, so just a couple of years ago, to me felt like the nail in the coffin. So without going through this whole study, but a huge number of patients, 1,850 patients, and this was a trial of patients who were randomly assigned one way or the other out of hospital cardiac arrest, and they looked at normothermia compared to hypothermia and found that really with all of the outcome markers that they looked at, there was no difference. So I thought I'd just sort of go around the room real quick here. And first, Scott, what are your thoughts? I'm guessing a couple of years ago you were probably doing therapeutic, post-arrest hypothermia. And I mean, does your institution do that anymore?
It felt like as long as it took, just like as everyone got ready to do the hypothermia, then this came out and everyone's like, all right, never mind. So it felt like there was so much momentum to get it there. But yeah, we don't do it anymore. For me personally, I think this study kind of put the final, nail in the coffin. And I will say, and I know we're maybe talk about this later, the neurologic prognostication protocol of the study was excellent to really help independently assess folks whether or not they thought they were going to have a good neurologic outcome. And actually, an independent takeaway for the study for me personally was, thinking about prognostication that way in the ICU setting.
Okay, so just quickly going around the room, Emily, are you doing therapy or what are they called? Targeted temperature management these days?
So we call it a code cool at our hospital, but we haven't done it in probably the last 2 years, really. We used to be real aggressive with it when I was resident, like 8, 9, 10 years ago. But we're not really doing it much
Code
anymore.
cool. Maybe you're not doing it because that's just such a like uncomfortable like set of words to say together. I don't know.
Yeah, no, they would page out around the hospital, code cool, and then
Code
whatever
cool.
room, and then they'd scatter and get the Arctic sun and call like an ICU nurse in, and it was like this huge thing. So
Wow. All right, Mike Palacci, I guess yes or no answer. Are you doing this anymore?
Uh, Not really, although they are doing some of the same measures just to prevent hyperthermia, but we're not
Okay.
trying to cool anybody.
Okay. And then John, obviously you work in the ED and in the ICU. Anybody doing this anymore?
So yeah, I'm going to push back a little bit.
Okay.
So at Penn, we still do targeted temperature management. The first decision is 32 to 34, so targeting 33 degrees. And then we do have some relative exclusions for 36, but even for our ECPR patients, we'll target 33 degrees sometimes. And I think it's because there's still some controversy. If you actually read the Dankowitz article, take a look at the patient population to see if they apply to you. And that's how we should read all these papers. Does this paper apply to my patient population, right? So 75% of those patients had a shockable rhythm, 90% were witness arrests, and 80% had bystander CPR, right? So now we're talking about a post-operative patient that had a witness arrest. So there's some application there. But I think for a lot of the patients we see in our emergency departments, those probably don't apply. In the United States alone, the actual incidence of bystander CPR is closer to 50, 60% if you're lucky. So that's a really important question of how long did this patient have no flow to their brain, and how bad's their brain injury going to be as a result of that. So take a turn, and there was a paper written by a great trialist in France, Jean, we call him JB Lescaro, right? So he looked at TTM in patients with basically non-shockable rhythms, PA arrests. This was almost 600 out-of-hospital cardiac arrests. Now, again, these were a lot of witness, so greater than 90% witness, 70% bystander CPR, and he compared 33 randomized 33 to 37 degrees. And of the survivors, so about I think it was around 20% of the patients in his trial had survival. If you looked at the survivors, the ones that actually left the hospital, there was a significant difference between good neurologic outcome and bad neurologic outcome. It was basically twice as beneficial. So 10% who got the targeted temperature management had walked out of the hospital, CPC score 1 or 2, versus 5% for those that got 37 degrees. So I think we don't know who the right patients are, things about like duration, severity of brain injury, if that matters. So I know there's been this big push to just go straight to 36 active temperature management for 72 hours and call it a day, but I don't think we're done just yet. So we still
Okay.
use 33 degrees.
Interesting. So, see, look, it's great to have that other thought and things there. And maybe just like the cardiologist loving the Lemke study, maybe all of us love the Dankowitz study because it just makes our life easier. That being said, it is a pretty good, when you think of all the other previous studies that have been done. And then there was just one, I think that just last couple of weeks with traumatic brain injury that looked at hypothermia with those and did not really find a benefit with that one. But anyway, sounds like, John, we're not 100% there yet. So I'm glad to have your thoughts on this. Okay, so here's what we're going to do. We're going to sort of find out what actually happened. So again, these are all real cases, and this is the actual documentation. So remember, the patient presented at 10:32, and soon after at 10:47, a progress note was written. Saw the patient immediately upon arrival. Good femoral pulse with mechanical compressions from the machine off. Showed AFib with RVR with a rate of 103, so RVR-ish, right? And no evidence of STEMI. Spoke, and this was at the time that conversation did occur with the cardiologist who didn't want to take the patient to the cath lab, of course. And then the family arrived and they gave some additional information, which the emergency physician didn't have initially, is that the patient did have some shortness of breath prior to his arrest and some confusion too. So now we have a little bit more of, and very still soon after the patient has arrived, a little bit more information. Not only is he 81, but we know he's post-surgical, and we know he had shortness of breath prior to the arrest. Now, still, John, like you talked about, you could have shortness of breath still from anemia or PE or sepsis, or some of the other things, MI. So I think the stuff that we talked about still are not completely excluded, but at least we have a little bit more information with it. So the patient does have a pulse, got a pressure, and is sent over to CT scan. And around that same time, labs return, showing the patient is severely acidotic, not incredibly surprising, hyperkalemic, a little bit anemic, but again, this is right after the arrest. And then it looks like acute renal failure and an elevated troponin level. So, Scott, the uh, the question for you would be the first one here. We do EKG. It doesn't show a STEMI, but the trope is very elevated. I think I know you answered this question. Do you call the cardiologist back and beg him to take the patient to the cath lab, or you're like, look, there's no way anyone's taking this guy to the cath lab?
Yeah, no, to me that just really remarks that this person had cardiac arrest, had their chest beat down for some period of time, and is going through a lot of metabolic and hemodynamic stress. I would be surprised if this patient's trope wasn't elevated for their age and risk factors, everything else going on. It doesn't really add much to my clinical, overall picture of the patient. And it's not going to change whether or not I call the cardiologist or change even my interpretation of the EKG.
Okay, gotcha. So, John, the CAT scan is done pretty quickly, and I know we've talked in the past with some of our other panelists, and the thought is, well, the circle of death, the donut of death, maybe that was a little bit of an old-fashioned terminology, like I sometimes like to say, the whole chest X-ray showing a tension pneumothorax as a marker of shame on the doctor who orders it. But if you do the chest X-ray and you look at the image on the machine while you're in the room, in the same way, you can pop the patient over to CAT scan that might be 2 doors down, and you do a CAT scan in 3 minutes, and the patient comes back. At least you have all this other information to help you go. So the radiologist reads the CAT scan, no pulmonary embolism, but it does show pulmonary edema. So tell me, how does all this fit together? It sort of makes sense with the patient had shortness of breath, but tell me what this means to you and what this means as far as the direction you're going to go with this patient, as far as either further diagnostics or management or even medications that you're going to start right at that time.
Yeah, it's a great question. So I agree with the CAT scan 100%. In fact, I'm pan scanning my patients post arrest at this point. There was a study published now 2-3 years ago where they basically took post arrest patients and CAT scanned them, and from head to toe, just like we do trauma patients. And the number of findings they found were, quite impressive. In fact, over 90% of them, they were able to identify some CPR related injuries, in addition to some things that actually lead you towards the etiology of the arrest. A second study was done a year after in 2020, over 200 patients, and they found the same thing. So I'm not just CAT scanning looking for one thing. I'm CAT scanning everything, to try to get as much data as possible. And, so now we got a patient who has pulmonary edema. And at this point, I still want my point of care echocardiogram to kind of get a sense of, now I'm thinking, okay, could this patient be in cardiogenic shock? Is that what led to his renal failure? And, tying it maybe together, even with this recent procedure, we know that there's actually a diagnosis called TERP syndrome that, it's a spectrum, but these patients get a lot of irrigation during the procedure itself, which causes these massive fluid shifts. And sometimes, and like this 81-year-old who has a weak heart might not have been able to tolerate that shift of volume and tipped them over the edge into cardiogenic shock. And that's what kind of potentially led to all of this. And so that's kind of how I'm tying it together at first. It has renal failure, low cardiac output, had a cardiac arrest, pulmonary edema on my CAT scan, probably a few other things. Now I need to really manage this complex cardiogenic shock patient, and start thinking about who I need to get on board to help me with that.
Okay, so let me do this. In just a second, Emily, I'm going to ask you about management of the CHF, And then, John, we can bring you back in for some other thoughts on that too. But right before that, Mike, you just like 3 weeks ago did like a Twitter post about flash pulmonary edema, and it was like, oh my gosh, there were like hundreds of responses, it seemed like, to that. And now there's a whole MCRIT episode going to be on that very same thing. So before, Emily, you talk about some of the management of pulmonary edema, CHF, flash pulmonary edema, Mike, just tell us just some of the other things that you learned from this incredible conversation that you started a couple weeks ago.
Well, the conversation we had a couple of weeks ago was about refractory scape, right? So a very specific scenario is a patient that we had at the time, and just massive dose, going what I considered massive doses anyway, 500 mics per minute of nitroglycerin for like 10, 15 minutes, and still not making the progress that we typically see with that. So to summarize it in a relatively short period of time, we don't want to talk for half an hour, obviously, but the idea was, what do you do next? Is it more nitroglycerin? Is it nitroprusside? Is it carvedilol? Is it nicardipine? Are there other options there? And I think the biggest take home I got out of that conversation and out of the podcast that Scott Weingart did afterwards was that probably the best place to go if you're not going to just keep going with more nitroglycerin, probably the best place to go if you have it available is carvedilol. Clofidipine. I'm sorry, clofidipine. Nicardipine is a very good option as well, but with the advantage of clofidipine is that it's shorter acting, and basically when you need to dial it down, you turn it down, it's going to go away faster, whereas nicardipine is going to stick around a little bit longer. So it was a really fascinating discussion as far as where to go and how high you can go with nitroglycerin. Going up to a gram or 1500 milligram or 1500 microgram. Let's try that again. Milligram or 1500 microgram boluses. I've learned new ways to get to big doses of nitroglycerin through that discussion.
So Emily, let's just create this scenario, say with our own patient here. 81-year-old man, post-Rex, maybe he's a little hypoxemic and whatever he is, but maybe a little even hypotensive. So nitrates aside, we talked about that just a little bit, or you can include those too. But what are some of the things that you're throwing at this guy? He's intubated. We know the tube's in a good position. He's got all this fluid, pulmonary edema on his CT scan, not a PE. What are you doing medication-wise? And maybe even, if you want, just sort of what doses are you starting with for some of the meds you're giving?
So, uh, CHF patients can be intravascularly depleted, even though they're fluid overloaded, right? So I always think it's a really good idea to get a baseline, look at that IVC, make sure that there's not major collapse of that. If there are, you can, and you have to be really cautious about this, but you can give small aliquots of normal saline, like 250 boluses, and reassess. But with this patient, if if they're fluid overloaded, I would start with some vasopressors. So I would start initially with Levophed or Norepi. You can titrate up. It starts at 0.01 mics per kilogram, and kind of titrate up. If that's not working, then you can add on epinephrine, which is similar dosing. If you have no blood pressure doing nitrates, you're just going to be chasing your tail at this point, and it's kind of, not very fun to do. You can also, I've done this before, is actually consult my cardiologist who comes and does an aortic balloon pump to actually physically give that heart a little bit of, in those coronaries, a little bit of perfusion. I've had to do that before with patients in the past who you just can't manage with medications, and they're in full-blown cardiogenic shock. You also have to understand like why they're in cardiogenic shock, right? Because you can throw all the meds at them in the world, but you won't be able to fix an aortic root valve regurg or some kind of septal wall rupture or some kind of structural issue. So you have to consider other sources of cardiogenic shock too.
So Emily, I'm so happy that you mentioned about the balloon pump and about talking about cardio, just for example, because in the end, I mean, we believe in medicines, but I mean, if you look at the history of the practice of medicine for hundreds of years, it was really just a scalpel. I mean, there were no really medicines that did anything for so many years. So yeah, our medicines now can be helpful, but sometimes you just need something mechanical, like for example, a balloon pump, you know. So there's no shame in this patient. We sort of know the hypotensive pulmonary edema patient is going to be super, super tough. And you already have the patient intubated, so there's not really much way to go from there. I mean, there might be some ways that you can manage your ventilator. John, I'm going to bring you in here because I want to have your thoughts on this. And I'm going to hold your feet to the fire a little bit. Some very specific, like, just putting up your eyebrows, right? Some very specific, like the medicines and the doses. Okay. But then I want to also have you just backtrack in a second here to a question from JJ about pan scanning with an elevated creatinine. So, the question is, would you wait for the creatinine to do your pan scan? And then if you do have the creatinine, would you still do the pan scan with contrast? So we'll save that for just a second here, but why don't we have you address, you got this patient in front of you. I think we all know the scenario. So very briefly, 81 years old, post-arrest, intubated, no PE, pulmonary edema, hypotensive, and hypoxemic.
Yeah. So I
You
guess
know,
my
there's a
first.
reason you did this with me tonight, right? I mean, I wasn't going to make it super easy, right?
So yeah, I guess my first question is, do we have a normal blood pressure? And I'm assuming we don't, right? So I'm not treating this patient like acute crashing sympathetic, pulmonary edema. Like this patient's in cardiogenic shock. So Emily stole a lot of my thunder here. This patient, we're really lucky to have her as his doc, because I mean, you really want to start by normalizing blood pressure, focus on coronary perfusion. Like I'm assuming like this patient's going to have a reduced EF, whether it's from stunning, post-arrest stunning, or it's just a low EF at baseline. Um, Number one, fix the mean arterial pressure first. So I want a map of 65 to 70 at a minimum. And I'm going to start with norepinephrine, number one, two, and three, absolutely. Now, once you've restored the map, if your patient's still in shock, you have to focus on forward flow and medications that will go along with it. You can choose an inotrope, like an inopressor, as some people might call it, like epinephrine. And for me, where I'm starting out on doses of these, if I really try to use our, University of Pennsylvania, we still don't use weight-based dosing, but I think it's you really have to be moving towards a weight-based dose, because 5 mics per minute on a patient, the 70-kilo person is fine, but we all know our patients come in all different shapes and sizes. So, something like 0.5 mics per kilo per minute to start is a reasonable start. And then I'm titrating up to effect. My norepinephrine, I'm bringing it up to get whatever I need to achieve a map of 65 to 70. Same thing. And that's that same dose for epinephrine. It's nice that they're pretty much the same. But if I think it's truly a low cardiac output problem, I'm starting at inotrope pretty quickly after I've normalized the mean arterial pressure. And that's the trick. If you want to start an inotrope like dobutamine at like 2.5 mics per kilo per minute to start, you have to make sure that map is okay, because those inodilators will drop your blood pressure like that. And then you're in a hole. It's never going to work. The patient's going to likely have an arrest. So fix the blood pressure first, then move to an inotrope if you have something like a low EF patient in front of you that you think's poor cardiac output, to get that cardiac index up. There are some tricks at the bedside that you can use. Like if you're comfortable with ultrasound, you can do something like a left ventricular, like a VTI. That's if you do one advanced measurement with echo and you want to learn something that's going to change your practice. For me, that's it. That's helped me calculate cardiac output without something fancy like a Pico monitor or a Swan-Ganz catheter, which we only use in the ICU. That's helped me make a decision about choosing an inotrope or not by actually using my ultrasound to measure my cardiac output. And then, you can, do a few other things to kind of check and see how you're doing after that. But I'm assuming we're at this point in a low cardiac output state. So pressors.
And just to briefly rehash one thing Emily said, as far as those boluses of 250 normal saline, you okay with that?
Sure. Yeah, absolutely. I think it's if you're doing a true fluid challenge, that's fine, but you have to stay at the bedside to see if it makes a difference. And it's not something you can just put in your Epic 500 cc bolus and then check back in to see how the blood pressure's doing. That's not how
Right.
it
Don't
works.
go to lunch. Yeah. So
Right.
before we get to the pan scan question I told you we're going to do, Scott, I want to have you come in also and see what your thoughts are on this hypotensive pulmonary edema patient. Um, you can say I agree with all of the above, or any other tips and tricks that you have that you use.
I mean, it's hard to disagree with any of the above. That's all the same stuff that I would do, and just really focusing on making sure you get those pressors started, get that blood pressure stabilized, and really this is the time to just kind of like keep it simple. Focus on those core measures, those things that are going to support the patient. I totally agree, John. Like bedside ultrasound to help you figure out if like a little bit of inotrope magic is necessary to help you find that wonderful balance of pressors could be really, really essential. Unfortunately, like this is the part where you have to just use your brain. Like there's not like a one size fits all algorithm for really stabilizing these folks when they could have like a multifactorial presentation of their shock. And so that's why I spent a lot of my time kind of thinking about, but I totally agree with everything that's been said.
Gotcha. So let's do this part real quickly here. John, just ask those couple sort of probably yes or no type questions. You order a pan scan with contrast, but you're doing that before the creatinine is back, similar to stroke patients, right?
100%. This patient's going to need dialysis regardless. So
Okay.
it doesn't make a difference.
Okay, good. So even if the creat is back and elevated, you still want to find out your source control, or in a sense, like what you're going to try to reverse, right? Get that information.
Yes.
Scott, you good with that?
I do not routinely order pan scans on ROSC patients. I'd love to get into that, but for this patient, yeah, it's a no-brainer. This guy's getting the CTA of the chest from me for sure. The creatinine, the only thing that's annoying about that is that phone call, because you have to be like, yeah, I know, like whatever. Of course.
You know you're getting that phone call. You don't even wait for them to ask the question, right? You're just saying like, yes, I want it.
It's
Okay.
already pre-written in my note that it's risk outweighs benefits. Like, let's get this thing on the road.
And they never see that note. It's like, didn't you see it? Oh, yeah, here it is. It's like they just wanted to call you. Okay, so here's what happens to the patient. And then we'll move to decision point 3. So 1239 spoke to the cardiologist. Obviously, they're not taking the patient to the cath lab. They don't have evidence of STEMI. They decide to admit to the ICU. The potassium is elevated, and the patient receives the medications that we typically would give, the calcium, maybe insulin dextrose, bicarb, whatever. And then the renal failure is recognized, of course, and the ABG shows 6.7 and a PCO2 of 37. So truly metabolic acidosis, of course, and again, not incredibly surprising, probably with the hypoperfusion. So let's move. We've addressed some of this stuff here, but I want to get to our sort of thought as far as talking to the family and as far as where we're going with the patient in just a second. We're going to sort of bring Scott into that. But John, I want to just sort of ask you, we got this ABG, I'll put it back up here. How does this change what you're doing with the vet? Now, look, I know you are like critical care EM, so like you're always super intensive. My suspicion is that most people in this country, they get the patient intubated, the respiratory therapist picks the settings. I'm just guessing. I'm not saying, I'm not blaming, I'm not saying it's right or wrong. No judgment from me. I probably do that a lot also. But so say the respiratory therapist put them on the standard AC16, blah, blah, blah. What are you doing now with this ABG with the vent, or are you really just concentrating on the perfusion?
Yeah. So there are some small changes you might be able to make to slightly improve this blood gas with a ventilator. But this patient has a normal PCO2. And even if you increase the minute ventilation by increasing your respiratory rate, even some people might even up it to 30, that pH isn't going to get anywhere north of 7 very far because this patient's in frank renal failure. So, the minimal things I might do is I'm still going to stick to my 6 cc's per kilo in this patient. We know post-arrest patients at high risk for ARDS and lung injury. So you can't change your minute ventilation much by increasing your tidal volume. You can increase it a little bit with your respiratory rate. check a blood gas again in 15 minutes and see where you're at. But other than that, that's it. I'm focused on the metabolic component of this,
Okay,
early acute acidosis.
gotcha. So metabolic. Now, I'll give you my own bias. I'm not much of a bicarb guy. Um, but in this situation, what is your thought? 6.7, or are you just going to address the perfusion?
Yeah, so I am a bicarb guy in this circumstance,
Okay.
and some people might try to quote the bicarb ICU trial that came out a few years back. That doesn't apply here. Those patients had a pH of less than 7.2, but their bicarb was probably around like 13. They were moderate renal failure. This is severe renal failure. Um, and here's the thing. This is the funny thing. When patients get dialysis, what do they get back? They get a bicarb bath. They get bicarbonate back, right? Because their kidneys can't absorb it. You've controlled the CO2 by intubating this patient. Give them some bicarb to at least try to get that pH up a little bit while you're arranging for dialysis, because that's the only thing that's going to fix this metabolic acidosis here. I try to get my pH closer to 7. And this patient, I'm guessing they probably have kind of might be an anion gap acidosis. I'm sure there's a little bit of lactate there, but it's definitely renal failure. So bicarb here for me
Mm-hmm.
would be a go-to.
And just very briefly, how much? What are you putting on your order? How much are you giving?
I'm just probably giving 1 to 2 amps of the
Okay.
50 milliequivalents of bicarb.
Gotcha. Okay, so I want to move on here, and the reason is because I want to give us all like at least 30 or 45 seconds to give our summary of teaching points. And I'm glad we're able to address some of the comments in the chat. I mean, these are amazing questions. Obviously, there's so much expertise here in the call. So, what happened to the patient? The family has now arrived. The patient had living will, it's critical condition, but they would like life-sustaining measures to be continued. The patient goes into cardiac arrest again. So, Scott, let me bring things over to you, and I want to have your thoughts on this, Emily, also. Shared decision making, obviously, is between two alternative, reasonable pathways, but it has to be done with our guidance. How are you guiding this family, Scott, given what you're seeing here and the fact that for them, they had a husband or a father who was talking in normal less than 24 hours ago and now is intubated, probably hypotensive and hypoxemic and keeps coding?
Yeah, this is a really tough spot to be in. And, if you want to look at it from like the principles-based bioethics approach, right, where we're trying to balance the 4 pillars of like justice, non-maleficence, beneficence, and patient autonomy. Here we have this conflict of patient autonomy, where they've expressed that so much in their living will, what they would like all this stuff for us to do, versus kind of like do no harm and do good for the patient. We have a moral obligation to provide non-medically futile care, right? When someone comes in, their arm's not broken, and they say, "Put me in a cast," you're not going to go uncast their arm, and I think we all feel very comfortable with that. But when it comes to end of life issues, or providing medical resuscitation that might be viewed as futile, it's a little bit more challenging of a conversation to have. I think here, if it was an easily, quote unquote, easily reversible cause of cardiac arrest, like this person degenerated into hyperkalemic arrest on en route to getting dialysis, and there was a potentially reversible option here, even though they're super, super sick and they have, multiple organs that are no longer functioning. I think in my role as an emergency physician, I think it's reasonable to attempt to reverse those things, but I would also frame it to the family as, hey, like, overall things are not going really well. They're really, really sick. And, I think it's both an acceptable option to call a code and say, if they code again, we're not going to try anymore for all the reasons we discussed. And if there is a positive outcome, positive being that you got ROSC again, kind of prep them for that ICU course, saying, I don't really know what's going to happen. I think there's a pretty slim prognosis. This would be a good time to get all the family together. I honestly, in this situation, I feel like getting the entire family into the hospital to say goodbyes would be like a reasonable goal for my resuscitation.
I mean, what we're doing really, we have all this expertise, these medications and the bicarb and the shifts and the this and the that. In the end, though, we're guiding this family to losing this patient, right? And that probably is the most important thing. I mean, of course, at this point that we're doing. Emily, give me some wisdom from your end.
So when I have these kind of cases, I like to go in, sit down, introduce myself, meet everybody in the room, ask them how that they know the patient, and then I talk about the patient like they're there. I use their first name and then I talk about, okay, I want you guys, I think the patient's name was Thomas. I want you guys to think about what Thomas would want. That way you're putting, less of the pressure on the family or the friends or the decision maker. You're putting less of that pressure. Okay, like Tom would not want to be on a ventilator, or Tom would not want a feeding tube, or Tom would not want to be on dialysis. You're kind of taking that pressure off of them, and it's actually very relieving, as a family member to do that. I also, I don't sugarcoat things. So this gentleman he's 80 years old, has multiple medical problems, and he had a prolonged downtime. So I'm going to tell him, listen, he probably went a significant time without adequate blood flow to his brain, meaning he might not ever be able to take care of himself again. He might not ever be able to have a meaningful conversation again. These are the things that are quite possible. I never say anything definite, right? We're not God. But I explain this to him. And then I talk about code status, what sort of things would he have wanted? And then if a lot of times they're saying, okay, we're gonna shift to a DNR, I do, especially in like a case like this, where a multi-system organ failure and very poor prognosis, I do talk about comfort measures only. And the way that I frame that is I talk about, listen, we have another pathway of treatment called comfort measures only. This is care that we provide up until the point of the patient passing away or death. We provide medications that make them comfortable, help with the feelings of anxiety and pain. We take away all the invasive monitoring. We make the room quiet and calm. And I talk about it as another care pathway because it really is. And I think it's super underutilized, especially, in the ER because we're off doing a million things.
Yeah,
So those are
that's
kind of the ways
great.
that I go.
Yeah, I love all those thoughts, especially not what do you want to do, what would the patient want to have done. So what happens is they have a family meeting, the patient gets admitted, and then they decide to make the patient comfort measures only, interestingly, and he subsequently expired. So what I'd like to do for the last couple minutes here, and I'm going to put the code up so folks can get their CME on this also. But for the last like 2.5 minutes, I just want to go like literally like 30 seconds. You can look at your watch of some take home points. I'm just going to start, if it's okay, by just sort of saying when I was the chair of my previous ED for a little over 4 years, almost 80,000 visit community emergency department. One of my great responsibilities as the chair was answering the patient complaints. And I remember a family once said, our whatever loved one, father, whoever died, the doctor came in and said, he's dead. And he turned around and walked out. And I'm like, first of all, there's no way that happened because the most busy or callous among us would never do that. But what I have shifted to doing is sort of, Emily, like you're saying, I wanted to come in, I wanted to sit down. I mean, it's like super scripted, right? I want to sit down and I wanted to spend some time with you and whatever, answer questions, all that kind of stuff. And so that's more like telling them that their loved one died as opposed to making that decision. But I love the fact that you say you are going to sit down, sometimes even saying in that scripting way that you are sitting down just helps them to remember that. And I like to check back in on them too. So why don't we just start with Scott? Why don't we start with you? We can go to Mike, then Emily, then John with maybe 30-second take home points from tonight.
Yeah, thanks. I think my big take home points is really just how critically decisive it is to tame the chaos in that post ROSC period. Really making sure that you're doing the simple things early and often, really getting your entire team motivated to get that initial EKG, get labs, support the map, and then figuring out, kind of like we talked about earlier, like what's your diagnostic approach going to be before you worry about anything crazy. Just taking 5 to 10 minutes to get a better sense of what's actually going on with the person and then move in the direction that makes the most sense for the clinical presentation, the information you have available, and what therapeutic options like make sense between those things. And I really do think the majority of the rest of my time, as everyone has already said here, is really focused on caring for the family in this part too, and making sure that they're on board with that plan and they can really kind of give more information around out what the patient would want in that situation.
Love it. Mike Palacci?
I'm going to go a little bit different direction with mine. I love a point that John made a couple of different times tonight in different contexts, during the course of the conversation, and that's to make sure that the decision aids or the evidence that you're using to make your decisions applies to the patient in front of you. Justin Morgenstern did a very long, comprehensive article on this a couple of months ago on why he feels that decision aids are ruining medicine. It was very controversial, very thought-provoking, but one of the points that Justin emphasized was exactly this, that if you're applying a decision aid or a study protocol to a patient that is different from the group that was studied, then all of the statistics that you memorized and that you're applying don't apply to this patient. So this application creep, this concept of application creep, it's a huge problem because you're applying a protocol to a patient who's not in the group that was studied, and it might not only not be helpful, it could actually be harmful. So John had two different examples where he talked about this tonight, and I just love the point. I think it's super important. It's something we really need to emphasize.
Nice. Emily?
Well, I think it's important to look at all those bleacher things that I talked about post ROSC to clean up your mess, especially like you had said earlier, confirming airway placement. That's huge, especially when it's done out of a hospital or outside hospital. And I do think it's consider hypothermia based on your facility and what you have available and what your patient population and what that case is. And then don't be afraid to do that CTA despite what the creatinine is. We're not here to save kidneys, we're here to save lives. So and not that that even really matters based on recent studies, but also take that time, sit down with that patient's family and talk about what's going on, because that's what they're going to remember from this. They're going to remember that time that you took to explain things. And don't be afraid to answer questions and summarize things and repeat things in multiple different times or in different ways, because I can't imagine sitting down and hearing a loved one had just been really sick and could potentially be passing away. I would probably hear 10% of that. So just make sure that you have kind of like a script, and make sure to answer all the questions.
John, bring it home for us, buddy.
Yeah, so I'm not going to really focus on all the clinical pearls. I think we went over a ton tonight. It was such a great discussion. I think this is a classic scenario of a really sick patient in the ED with a likely poor outcome. But unfortunately, we don't have a crystal ball and we can't predict the future. If I could leave medicine with one thing that would be different, it would be to remove the apathy and nihilism that has grown, I think, in medicine of things don't work from all these negative trials and studies. And it's just because we're not asking the right questions. Sometimes admitting that patients to ICU, and I get these patients all the time, working at CT SICU, we take care of these really sick ECMO patients. Like there's occasionally that groan of like, oh, this patient's not going to do it. Yeah, they probably won't. But at a minimum, what we can offer is some more time to get the family around, get the loved ones around to say their goodbyes. And that's really meaningful. And I can honestly say, though, the more I've practiced medicine, the more surprised I am to see what actually happens on hospital day 3 to 10. It's not what I would have thought on hospital day 1. So, I agree. This patient's likely not going to do well, but if there's a chance, we should go for it.
Well, thank you so much to our panelists, John Greenwood, Emily Hammer, Mike Placci, Scott Kovner, and mostly thanks to all the folks that have given us 1 hour of your life on a Monday night. And hopefully, most importantly, this will improve our care of patients, not just medically, but also from our relation with the family. Families need to know that everything was done and that the wishes of the patient were the things that prevailed. So thank you, everyone, so much again. Hopefully, we will see you on October 2nd. You can always sign up. Registration links are on embouncebacks.com. And we also have QR codes that we share with Twitter or Facebook, different social media places too. So thank you all so much again. This will be posted by tomorrow for anybody that wasn't here that wants to watch it. And enjoy the rest of your evening. Thanks again.
Have a great night, everybody.
Thank you.
Have a great night, everyone.